So let's do a second example. A 2-year-old girl had dysuria and a 38-degree fever and was treated with antibiotics. The urine culture was positive for coliform bacteria. This was her first time getting a UTI. Her symptoms had disappeared 2 days after initiating antibiotics. What should be done next? So what is the diagnosis here? Is it a straightforward UTI? Is it an atypical UTI or is it a recurrent UTI?
Straightforward.
Yes, it's a straightforward UTI, and a straightforward UTI does not require any imaging in children older than 6 months. So here the age of the girl is 2 years. So again, the management will be no further action is required. So only reassurance. If the child age was less than 6 months, or if the girl was 5 months old with a straightforward UTI, then what would have we done? What imaging is done? What imaging is done in a straightforward UTI in children or infants who are younger than 6 months?
MCUG.
In straightforward UTIs, because the cause of straightforward UTI is mostly coliform bacteria. That's why no other imaging is done. Only ultrasound is done.
Okay.
Only ultrasound is done because DEMSA scan and MCUG. DEMSA scan is to check renal scarring, and MCUG to see if there is any reflex, vesico-ureteric reflex. So in case of straightforward UTI, renal scarring and vesico-ureteric reflex presence is very less likely. So that's why they are not done in case of straightforward UTI. Only ultrasound is done, and that too within 6 weeks of the infection.
Okay.
So in case of straightforward UTI, only ultrasound will be done in children who are younger than 6 months, and children who are older than 6 months, no imaging will be done.
Right.
You can see in these tables. In children who are older than 3 years, no ultrasound within 6 weeks, no DEMSA scan, no MCUG. Similarly, you can see here, no imaging is done. Similarly, you can see here, only ultrasound is done, that too within 6 weeks, if straightforward UTI and the infant is younger than 6 months.
Right.
Let's do another example. A 5-year-old girl had dysuria and was given with antibiotics. The urine culture was sent. This is also a straightforward UTI, so no imaging will be required. A 5-year-old girl had dysuria and given with antibiotics. This was her first time getting UTI. Her symptoms did not improve 2 days after initiating antibiotics. So the symptoms does not improve after initiating antibiotics. So what is the diagnosis here? Antibiotics.
Atypical.
Yes.
Atypical UTI.
Yes, atypical UTI in any age group. So this is another line that you can remember. So that is atypical UTI in any age group. Immediate ultrasound will be done.
Right.
Your voice is breaking down. Can you please speak again?
Okay, yeah, that's fine. So it's ultrasound. It should be done urgently, yeah?
Can you hear me?
Yes, I can hear you now.
So, so atypical UTI in any age group, ultrasound will be done immediately during an acute infection.
So why is it saying DEMSA scan 4 to 6 months after the acute infection? Another correct answer is
I don't think so. This is another correct answer. DAMSA scan cannot
right.
be older than 3 years. Then only imaging is that is
Ultrasound.
done is ultrasound, immediate ultrasound.
Right.
If this girl was less than 3 years old, then DAMSA scan could have been an answer, because this
Okay.
answer it contradicts this table, and this table is an
Okay.
updated one and it's the correct one.
Right. So DEMSA scan is done when there is a repeated infection, like a recurrent
Recurrent
UTI,
UTI.
and it detects the scarring.
Yes, DAMSA scan is
Right.
done if there is recurrent UTI or if atypical UTI in younger in children who are younger than 3 years.
Right.
So straightforward UTI does not require any. This is one principle. Atypically UTI in any age group, immediate ultrasound will be required. This is the second principle that you need to remember for UTIs. So a 2-year-old girl have had 2 episodes of lower urinary tract infection within the past year. She is now having a third episode. What should be done? So 3 episodes of UTI within a year. What is the diagnosis? Recurrent UTIs. So recurrent UTIs older than 6 months. Here the children is older than 6 months and younger than 3 months. The management of recurrent UTIs in children who are older than 6 months and older than 3 years is same. And what is that? Let's see the table. That ultrasound within 6 weeks and DAMSA within 4 to 6 months. So in children who are older than 3 years, ultrasound and DAMSA scan. Similarly, who are younger than 3 and DAMSA within 4 to 6 months. So management of recurrent UTIs in children who are older than 6 months is same. And children who are younger than 6 months, they are a different case altogether. So you need to memorize them separately from these asked in the Plab 1 about UTIs in children. Now let's discuss some general points about UTIs or urinary tract infection in children. Remember that UTIs are more common in boys until 3 months of age due to more congenital abnormalities. And after 3 months of age, UTI is substantially higher in girls. Now, the presentation of UTI depends upon the age of the patient. If an infant, he will present with poor feeding, vomiting, and irritability. So the presentation of UTI in infants is poor feeding, vomiting, and irritability. In younger children, abdominal pain, fever, and dysuria. In older children, dysuria, frequency in hematuria, and features which may suggest an upper UTI. They include fever more than 38 degrees centigrade, so high grade fever with loin pain or tenderness suggests an upper urinary tract infection. Now, a urine sample is needed to confirm the presence of UTI, and a clean catch sample of urine is preferable. If it's not possible, then urine collection pads should be used. Cotton wool balls, gauze, and sanitary towels are not suitable. So if clean catch urine is not possible, then we can use urine collection pads. And if that's also not possible, then suprapubic. So the only method to obtain a clean catch urine sample, if urine collection pads or other non-invasive procedure are not suitable, not possible, then we can do a suprapubic aspiration. Now, and in infants with UTI who are less than 3 months old, they should be immediately referred to a pediatrician or a secondary care. And children aged above 3 months with an upper UTI should be considered for admission to the hospital. So they should be admitted to the hospital if there are signs of upper UTI such as high grade fever with loin pain or tenderness is present. And antibiotics such as cephalosporin or coamoxiclav should be given for 7 to 10 days if there is upper UTI. Lower UTI should be treated with oral antibiotics for 3 days, and the antibiotics that include to treat lower UTI include trimethoprim and cephalosporin and amoxicillin. They can back if they remain unwell after 24 to 48 hours. Antibiotic prophylaxis is only given if there is a history of recurrent UTIs. Now, straightforward UTIs are those that respond well to antibiotics within 48 hours, and atypical UTIs include UTI that does not respond to antibiotics, and the child is seriously ill, poor urine flow, abdominal or bladder mass. These are some features of increased creatinine, septicemia, and infection with non-E. coli organisms. So these are the features of atypical UTIs. UTI that does not respond to the treatment, UTI with severe signs and symptoms such as seriously ill or septicemia, increased creatinine level, poor urine flow. These features are present, then your diagnosis will be atypical UTI. And recurrent UTIs, 2 or more episodes within 6 months and 3 or more episodes within 12 months will make the diagnosis of recurrent UTI. Now, some points about urine dip stick testing. Urine dipstick testing is done, and if both leukocyte esterase and nitrite they are negative, then UTI is less likely. Because if on urine dipstick testing leukocyte esterase and nitrite is not present, they are negative, then we do not need to start antibiotic and we do not need to send a urine sample for microscopy and culture. If leukocyte esterase or nitrite both are either one of them or both of them are positive, then we need to start empirical antibiotic treatment and send the urine for culture and sensitivity. Clean catch urine sample or midstream catch. So midstream urine sample is preferable or is the method of choice for urine collection by NICE guidelines. And if it's not possible, then urine collection pads. And if that's also not possible, then suprapubic aspiration. So vesico-ureteric reflex, what is vesico-ureteric reflex? Vesico-ureteric reflex is the retrograde flow of urine from bladder to the ureters and kidneys. Vesico-ureteric reflex is usually asymptomatic and it may present as UTI due to increased, because with vesico-ureteric reflex, the risk of UTI is increased. So vesico-ureteric reflex may present with recurrent UTIs. Initial investigation is urine analysis, urine culture and sensitivity, and renal ultrasound is done. And renal ultrasound will show urethral dilatation due to backflow of the urine. And the gold standard to diagnose a vesico-ureteric reflex is micturating cystourethrogram. And to see parenchymal damage or renal scarring, DMSA scan is done. Now, how we are going to manage vesico-ureteric reflex? If grade 1 to 5 vesico-ureteric reflex is present, the grade is decided on micturating cystourethrogram. Then we need to give low dose antibiotics such as, and if the prophylaxis is failed, or if there is parenchymal damage or renal scarring, or if there is breakthrough UTI, that is, even the patient will get UTI even on low dose trimethoprim, or if there is persistent high grade reflex, that is 4 to 5, then we need to do a surgical correction. Because in most cases, VUR is due to abnormal insertion of ureters into the urinary bladder. So normally low dose antibiotic prophylaxis is done, and if this prophylaxis is failed, or if there is parenchymal damage, or if there is breakthrough UTI, or if there is persistent high grade reflex, then surgical correction is required. So this was all about UTIs in children and imaging schedule and some short description of vesico-ureteric reflex. I hope it's clear to everyone.